Hello, hi. Hope you all are doing very well. This is Dr. Itsham, and today we are going to talk about the rheumatic fever. We're going to discuss in detail about the pathogenesis, about the diagnosis, major minor criteria, the tissues and organs which could be involved in rheumatic fever, and what's the treatment. So let's start. Rheumatic fever is actually caused by group A beta hemolytic streptococcus, and particularly this is the rheumatogenic strain. So what happens is that this bacteria, this causes the pharyngitis. And what happens is that in few people, particularly those who are genetically predisposed, and those are only 2 to 3%. So out of the all people who are getting this pharyngitis from this group A beta hemolytic streptococcus, only 2 to 3% who are genetically predisposed, they develop this rheumatic fever. How does that happen? This our immune system, this produces the antibodies against the streptococcal antigens, particularly the M protein of the streptococcal antigen. And why it does so? Because our immune system tries to clear these bacteria. But what happens in addition to clearing these bacteria, producing these antibodies, which our immune system is producing, these antibodies also attack our own tissues. The people who are genetically predisposed to that one, they're only 2 to 3%. These antibodies, they destroy the bacteria on the one hand, and the other on the other hand, it attacks the own tissues as well, the body's own tissue, like the heart, the CNS, the joints, and the skin. Okay, and why does this happens? Because these M proteins of these bacteria, they are quite similar in structure to the proteins which those genetically predisposed peoples are having on these organs like heart and all that. So our their body, what that does is that it clears the bacteria, but at the same times, because of this molecular mimicry, okay, they get baffled and they attack their own tissues at the same time. So attacking the bacteria at the same time, but they are confused because of this similar molecular structure on different tissues, so they attack these tissues as well. Okay, which tissues are involved? It's heart, it's CNS, it could be joints, it could be skin. They all could be involved, or either of them could be involved. So let's discuss one by one and what symptoms they are producing. So if the heart is involved, so it could involve either the pericardium, it could involve the myocardium or the endocardium, or it could involve all of the three. So it could be pericarditis, myocarditis, or endocarditis, and it could be pancarditis. In the brain, it involves the basal ganglia actually. So these people, they produce the symptoms, which is called chorea, that is involuntary movement of the limbs. It could be one of the limbs, or it could be the other limbs. This could happen. We're going to discuss about the carditis in detail afterwards. Let's discuss these things first. So it involves the basal ganglia producing the chorea, and we call it Sydenham chorea. This chorea can develop during the rheumatic fever. It could involve after a few months. And the good thing about this is that there's a complete recovery. Now, in the joints, it could cause either arthralgia, that is, there's no swelling and no inflammation. That is in the minor criteria. We're going to discuss that one in detail. Or it could cause inflammation and swelling, that is arthritis. If it's without the inflammation and without the swelling, it is arthralgia. If it's with that, that's called arthritis. And the arthritis in rheumatic fever, that is migratory polyarthritis. Good thing about this is that's also completely recovers. In the skin, it could form subcutaneous nodules, that is on the extensor surface, or erythema marginatum, and that is also that goes away, that completely resolves. Actually, if you realize this thing, what we are discussing at the moment is also the Jones criteria. We're going to discuss that one later on as well. Okay, let's talk about the heart. That is important. So in the heart, it could involve either the pericardium, that is pericarditis, that completely resolves. The other thing is that it can involve the myocardium, that is the tissues of the heart. So myocardium, either this completely resolves, or either that could lead to the heart failure and kills a patient. By the way, this rheumatic fever that occurs particularly in the age of the children 5 to 15 years old, when they are 5 to 15 years old. So myocardium is involved, it's called myocarditis. Either it completely recovers without anything, or it leads to myocarditis that leads to heart failure and kills the patient. So if a child dies during rheumatic fever, it's most likely because of the myocarditis. Now let's discuss about the endocarditis. So you know that the heart valves, okay, they are covered with the endocardium. So what happens is that when there is endocarditis in the rheumatic fever, so the heart valves, they get damaged. There's inflammation, there's vegetation over there, but this vegetation is fixed as compared to the rest of the vegetations like that occur in infective endocarditis. But there is a damage, there is inflammation. Okay, so our body tries to heal that one, but this heals by fibrosis. So the fibrosis leads to the calcification over the valves. Now, the next time when they attack, there's another attack, same process goes on. And every time there's healing by the fibrosis, there's a damage to the valve, and there's a healing by the fibrosis, and there's a calcification, and that carries on with every attack. So what happens as an end result? Your heart valves become stiffened. That's and what we get in most commonly in the rheumatic fever, that is mitral stenosis, and after that what is most common is aortic stenosis. So mitral is most commonly involved, and then the aortic is involved. So you can see from this thing is that this is not a short-term thing. It develops over number of repeated attacks, and it takes a couple of it takes time actually to develop this rheumatic valvular disease. Okay, so now next, let's talk about the major criteria and minor criteria. That is actually the diagnosis of rheumatic fever as well. So we have discussed this thing earlier as well. Joints, you know that JONES. That's how we try to remember this thing. So joints, we already spoken about that. Migratory polyarthritis. O is for carditis. It could be either of them, peri, myo, or endo, or a pancarditis involving all the three. N is for nodules, subcut nodules. We have already spoken about that. E is for erythema marginatum. We have spoken about that. And the S is for Sydenham chorea. So hard is actually something that is different here. The rest of the things, they completely resolve. In the heart, pericarditis resolves completely. Myocardium, either it's going to resolve completely or it's going to kill the patient. And the endocarditis, because it's endocardium that's lining the valves of the heart. So the damage over the period of the time, that leads to calcification and the stenosis, and that leads to long-term complications regarding the heart. You might need a heart valve replacement if it is that much stenos. So the minor criteria, if you come to the minor criteria, that is fever, arthralgia, not the arthritis. The arthritis is in the major criteria. Increased inflammatory markers, leukocytosis, previous attacks, and also the AV blocks. So either you have the two major criteria, or either you have one major and two minor criterias. If you have this thing, like, you can make a diagnosis of the rheumatic fever. And it's important not to miss the rheumatic fever, because over the number of times it's actually the cardio involvement that's going to disturb the patient most. It could either kill the patient, or if it's not, its endocardium is involved, later on in his life it's going to develop a stenotic valve, and that's going to trouble a patient and might need a valvular surgery, replacement surgery. So this thing could be easily avoided if we diagnose the rheumatic fever earlier. Okay. What other things we can do is the ECG. That's going to tell you about the AV block, the minor criteria. The echo, that's going to tell you about the vegetation, stenosis. CRPS or raised WBCs, ASO titer. You can do throat culture and chest X-ray. Chest X-rays particularly can tell you about the failure when you have pulmonary congestion and all that stuff. But that criteria plus these are the certain things you can do here. Okay, let's speak about the treatment. So the treatment is a bed rest, and it's a bacterial thing. So you need to give the patient antibiotics, and that's penicillin V, or that is oral, or you can give the benzathine penicillin, that is IM. If someone is allergic to the penicillin, the other choice is either erythromycin. You can give erythromycin, or the rest of the macrolides like azithro or clarithrol can be given as well. So the bed rest, antibiotics important. If there is a heart failure, like in a myocarditis, treat for the heart failure. If there is arthritis, then you can give the aspirin. So aspirin really helps in the arthritis here. And you give 60 mg per kg in divided doses, like 4 divided doses, 3 to 4 divided doses in a day, and it gives you a dramatic response. And the steroids in that case, where the aspirin is not working, you can use it for the myocarditis as well if it's not improving. That's an as a last resort you give that one. Okay, the other thing that is important here is about um, the prophylaxis. If someone is having a rheumatic fever, this means that he is not predisposed to this thing. Whenever he's going to develop this pharyngitis caused by the group A beta hemolytic streptococci, he can develop the rheumatic fever. So you need to prevent that one. You need to prevent the heart actually. Okay, so rheumatic fever, if he's having a rheumatic fever without carditis, so you give 5 years after the last attack, or 25 years of the age, whichever is longer. What you give either benzathine penicillin, that is given one injection over a month, or you can give oral penicillin daily as well. So if someone is having a rheumatic fever, you're going to treat that one, and you're going to give the prophylaxis as well. Okay, so you can give either for the 5 years, okay, if it's without carditis, or 21 years of the age. It reaches a 21 years of the age, whatever, whichever is longer. Okay, if it is with carditis but there is no residual valvular disease, so you give it for 10 years or for 21 years, which of the age, whichever is longer. And if it's with the valvular heart disease, so you have three things: rheumatic fever without heart involvement, rheumatic fever with carditis but not the valvular involvement, residual valvular disease, and the rheumatic fever with valvular disease. So if it is with the valvular disease, you're going to find that one on the echocardiography. So you give it for 10 years after the last attack, or the 40 years of the age, whichever is longer. Sometimes you need to give here for the lifelong as well, because here now there's a persistent valvular heart disease. When I was going to have a rheumatic fever, that's going to add more fuel to the fire. So you need to prevent that one. Whatever is stenosis. You don't want more stenosis. So you have to give sometimes the lifelong as well. What you give is you give benzathine penicillin, a monthly injection, or you can give penicillin V 250 mg twice daily per oral. And for the individuals who are actually allergic to the penicillin, you can give the erythromycin 250 twice daily. So that's all about the rheumatic fever. Hopefully that's going to help.